Hello and welcome everyone to today's Scottish Drugs Forum webinar. I'm Dave Little, CEO of SDF, and I'll be chairing today's session, which will run no later than 2:20. This is the last in a series of webinars focusing on the medication-assisted treatment standards from 1 to 10. The aim of the webinars is threefold. Firstly, to continue to raise awareness of the standards. Secondly, to highlight emerging good practice. And thirdly, to highlight challenges that remain with full implementation and how these may be overcome. Today we'll be focusing on MAT Standard 10, which is as follows. All people receive trauma-informed care. The treatment service people use recognises that many people who use their service may have experienced trauma, and that this may continue to impact on them in various ways. The service is available, and the people who work there will respond in a way that supports people to access and remain in services for as long as they need to, in order to get the most from treatment. They will also offer people the kind of relationship that promotes recovery, does not cause further trauma or harm, and builds resilience. A link to the full standards is provided in the chat. We have two presentations today. Firstly, Adam Burley, who's consultant clinical psychologist with Simon Community Scotland. And secondly, Katie McLeod, research and peer engagement program manager with the Scottish Drugs Forum. Presentations will be followed by a Q&A session. You can submit questions through the webinar, throughout the webinar, through a Q&A tab on your toolbar. My colleague Austin Smith will be monitoring questions as they come in, and will join us for the Q&A and summarise questions being asked. So let's get started with our first speaker. Thanks, Adam.
What I wanted to do was focus on a particular part of trauma-informed care that really relates to access. So I know there's a lot of material around trauma-informed care, but I'm really going to sort of try and focus on the access bit, and I can come on to how that relates to other things. Because interestingly, looking through all the other MAT standards, there is sort of an assumption in some of them, 6 and 9, that when somebody gets somewhere and is in treatment, then we will do this and we'll do that, and they'll have access to this and access to that, which I think is all well and good. But there is something I think fundamental about what I understand as trauma-informed care, which is about access. So we could next slide, thanks. And I really want to start with a sort of fundamental idea, which won't be news to many of you, but it's really around a notion that all healthcare is relational at a very fundamental level. That I would argue also that all human activity is fundamentally relational from the very first moments that we arrive in the world. Our health, well-being, psychological health, physical health is dependent upon our capacity to form and maintain relationships and get into relationship with people who might be able to help us, treat us, care about us, that sort of thing. Next slide, thanks. To sort of turn the volume up on that, I would argue really that relationships are the psychological equivalent of breathing, really. In that, just like breathing, when breathing is relatively invisible, we don't notice it. We've all been breathing since we started this webinar. In fact, most of us have been breathing since but we're so skilled at it, so good at it, that we don't even notice we're doing it. We don't come at the end of the day and say, another successful day of breathing, aren't I clever? And similarly, but actually, if anyone's seen anyone choke or choke themselves, they will realize that when that happens, you realize that breathing is actually everything. It's the whole sort of shooting match, really. And if you're not breathing, then not much else is happening, really. And I would argue that relationships are a bit like that. They're similarly invisible. If we're good at them, we don't really notice we're doing them. We go around making friends and colleagues and partners and joining clubs and doing all sorts of stuff, accessing healthcare, for example, not really thinking that it's our relational capacity and our relational capital that's allowing us to do it. But for a lot of the people that I guess I've worked with over the years, there's a lot of relational choking that goes on, and it really interferes with someone's capacity to sort of form and maintain relationships and access all sorts of things that might be good for their health and well-being. We could have the next slide, thanks. And in relation to trauma, I would argue that, or one way of thinking about one of the real long-term consequences of trauma, or primary sort of impacts of trauma, is that it causes a severe and long-lasting relational injury. That's sort of my terminology, really, that it is an instance of disconnection, that interpersonal trauma through early years can really impact upon a person's capacity to trust in others, to form those sorts of relationships that most of us sort of might take for granted. And the repair of that, which we'll sort of talk about a bit further on maybe, is, I think, a long-term project. And at times, there's someone I worked with for a long time who described our relationship at some point after 10 years, this was, to say, well, I think I trust you a bit, but I think I'll always speak trust as a second language. And that really stuck with me, because I think it really speaks to something of the severity of the injury, and how the first things that were learned were much more about not trusting and not connecting and not reaching out and not having need and not taking care, particularly from others, because to take care from others is dangerous, to rely on others is dangerous, to even try and relate to others is dangerous. And I think that's an incredibly severe injury, because there's something utterly fundamental about needing relationships. And so to have that sort of injury is like a bird learning that to fly is bad, and spending the rest of its life sort of on the ground, scared of flapping its wings. It's that sort of fundamental, really. So we could come on to the next slide. So when it comes to things like accessing healthcare treatment, medically assisted treatment, to be trauma informed, I think, needs at some level to recognize how relational injuries, and we must understand that a fair amount of people who have strong relationships with substances and might be in the running for medical assisted treatment will have severe relational injuries. And so a lot of our processes, whether it's letters inviting people to appointments, or if we look at the next slide, or where we meet people, which is often in buildings that we've built and that we've organized and that we've designed, sort of assume that people can breathe easily, that they can do relational breathing, quite the thing, that they can come along and connect, and that they have that sort of relational access, that they can make use of services. So when they get there, they can have those psychological treatments, and they can have mental health care at the same time as having MAT. But it all really is based around an idea that they can get there. And I suppose what I want to sort of argue really is that we might need to have, as part of the treatment, if it was going to be truly trauma informed, we might need to recognize for some of the people who are in the greatest need of treatment might have the least ability to relationally access the services that that we have available. So we could have the next slide, thanks. To the degree where if we compared relational injury, I'm aware that this is a poorly defined term because I've sort of made it up, but if we compared relational injury to sort of severe physical injuries, and the adaptations and accommodations that we make for people with physical injury, I don't know that we make those sort of adaptations and accommodations for relational injury to the point where, like, for example, that letter, the buildings that we showed a minute ago, and asking someone to come and access treatment in those sort of places with those sorts of times and appointments to meet new people in new buildings might be the equivalent of putting a wheelchair clinic at the top of 3 flights of stairs and asking people to turn up on time. And then more than that, locating the blame for not turning up in the person who didn't turn up, because we can't see the invisible relational stairs that we've put between us and them, really. And we wouldn't get away with this in physical injury. In fact, it would be, I think, relatively illegal to set up a service that didn't make adaptation and accommodation for the long-term consequences of physical injury. But it's much harder to find the sort of adaptations and accommodations that we make for the long-term and often, as I say, permanent sort of consequences of relational injury. I think what was really striking about that lady's comment about speaking trust as a second language is that she was really speaking to something of the permanency of the injury, that there may be recovery, there may be bits where it might be easier to connect with people and there's a capacity to trust. But I think she was speaking to the heart of how early the injury was and how much in the bricks it was, that this was very much a part of how she understood the world and the limitations it sort of placed upon her, really. So if we could have the next slide, that would be good. So again, thinking back to the sort of relational stuff, I would sort of perhaps suggest that relationship with substances is its own sort of medical assisted treatment, that somebody might be addressing the relational needs they have through being in relation to substances. I think we all do that. So this family up in the top right, they have needs, they have relational needs, and they're able to get them met through accessing other people and having children and having friends and jobs and all the rest of it. Whereas perhaps someone who's experienced a high level of trauma and as a consequence has this sort of relational injury, then when they meet substances at the age of 13 or 14 and get into relationship with them, it may be one of the first relationships that they've ever really been able to trust and rely upon and depend upon. And often we're inviting people to break that dependency, but not really providing something else to be dependent upon. I'm definitely of a mind that we are all fundamentally dependent. I'm pretty proud of my dependency on all sorts of things. And I think if you dumped me on a desert island and disconnected me from my family and my partner and my friends and my records and my bikes and all the other things that hold my fragile sanity together, then I don't think I would look the way I am just now. But luckily, I think I have enough relational capacity to form relationships with people and others, and through that get my emotional and sort of psychological needs met, really. I can access things, I can access healthcare, I can access leisure, I can access other relationships, really. And to that regard, these people in the top right corner are in permanent treatment. They are getting their emotional and psychological needs met by being in relation to others, really. So if we could go on to the next slide. So I'm sort of really arguing for that as part of, if Matt 10 is to be taken as read, then I think part of it being trauma informed would really need to understand that relational repair and bridging those sort of relational gaps and a repairing of trust and repairing of relational injury would have to be an essential part of treatment, not a sort of ancillary part or a precursor to it, but an integrated and fundamental part of treatment. And that might speak to where we meet people, not where they come to meet us, but where we go to meet them, and what might be required before we even talk about the medicine. What sort of relational scaffolding and connection might need to be built before someone could actually make use of the goodies that we have available, whether that's, as I say, the medical assisted treatment or the sort of psychological care and all the rest that we are arguing they should be able to get when they come and see us, when they manage to get to the top of those stairs. And I suppose what I'm arguing for is we might need to have some processes and things in place that are part of the treatment that might allow somebody to climb those stairs in the first place. I've worked with people over many, many years who may greatly benefit from psychological interventions, primary care, medical assisted treatment, all sorts of stuff. And it's not that those treatments aren't there, it's that the person's capacity to trust in the people who deliver those treatments, to trust in the relationships through which those treatments might be delivered, is so injured and so damaged. And we have so little services that attempt to repair that they are very unlikely to climb those stairs to ever get to the goodies through the door at the top of them, really. So we could have the next slide, really. Again, these are sort of slightly daft analogies, but this is to try and shine a light in my own mind on what I'm trying to try and articulate. And I do think it's hard to articulate. I find it hard to articulate because relational capital is a sort of invisible construct, really. But I don't think we would ever, if we wanted care for people who had suffered trauma in car crashes, and we have that sort of care, and we wanted to make it trauma informed, part of that would be making sure that the person could access that care to the point where we wouldn't go along to the motorway site where there's been a crash such as this and say to people, you really need to go along to A&E and get that smashed pelvis looked at, and you really need to get into an operating theatre and have your spleen operated on. Like, we would never say that. It would be ridiculous, because we would understand that part of the trauma has led to an injury which might make it difficult for the person to access all the goodies that are not at the site of the trauma. they are somewhere else, and that access between where the person has been traumatized and where they might get treatment is a fundamental part of the treatment, because all of those goodies in hospital are as to nothing if the person cannot access them and cannot make use of them. This is a much more physical and visible version of it, but as I say, for people who have experienced the greatest levels of trauma, I would argue that the relational injury can be so severe that accessing and making use of the services we have available is not possible without proper care of the relational injury. So if we could come on to the next thing. So we do have services that will attempt to sort of rehabilitate, for example, spinal injuries or other physical consequences of physical trauma. We've gone to the next slide. But in terms of the sort of slow, historical, and often invisible car crash of childhood trauma, childhood adversity, neglect, and mistreatment, which we don't often see. We're usually seeing the consequences, often the late emerging symptoms, whether that's relationships with substances, mental health problems, homelessness, involvement with the criminal justice service. We are seeing late emerging problems that relate to early relational injuries that we don't see, and we can't see them because they're in the past. If we could have the next slide, thanks. And so far, I've yet to see the relational injury rehabilitation service, the trust repair service that might be a necessary and integrated part of any treatment service that aims to be truly trauma-informed and recognize the relational and access consequences of severe and early trauma, that people will be left with long-term complicated relationships with care itself. And I think it's all well and good to say, when you get here, we will have this, we will be trauma-informed, we will have psychological therapies, we'll have primary care, we will be in this one place, you can get everything while you're here. But it still requires the person to in some way get there. And it's that sort of relational access that I do think is one of the long-term and really life-limiting consequences of trauma. And I think that needs to be a central part of what we call trauma-informed care that's described in MAT Standard 10. So we come to the next slide. As I say, we find it easier in more visible areas to make adaptations and accommodations for the consequences of physical injury, whether that's ramps, widened doors, accessible toilets, all sorts of things that allow people who have the physical consequences of often trauma, be it a car accident or something else, to access the healthcare that they might really desperately need. And again, it would be, I think, in many cases against the law if we did not provide those adaptations and accommodations for the injury and the consequences of that injury. But it's much harder to find the sort of adaptations for relational injury that would allow people who have been harmed the most within interpersonal relationships, and as a consequence of that have been left with what should be deeply understandable misgivings, ambivalence, and at its most severe, massive mistrust of anybody who says they're going to care for them or help them or treat them. And I think there is things that we can do to address that. I think there's organizations who inadvertently, I think, are providing trust repair services, that it's often not valued or not seen as being important, or often being seen as a precursor to treatment rather than as a fundamental part of treatment itself. That if we are going to deliver medical assisted treatment in a trauma-informed way, then to repeat myself maybe for the 100th time, I think that access and relational access needs to be a central part of that. And to be trauma-informed would understand that climbing those relational stairs, jumping those relational hurdles, and making connection with people to allow treatment to happen may be the one thing that people understandably can't do because of their traumatic experiences. Can I have the next slide? I think this is just the question. So I quite like this as an ending slide because it's quite funny. But I suppose it speaks to the idea of we often sort of speak a lot about what we might provide for people and what we're doing, without really spending a lot of time thinking about how we've positioned ourselves in relation to the people who might benefit or need some of the services that we have the most. There is, I think, an implicit assumption often within health and social care services that people can relate to care in a relatively anxiety-free way. But I think for the people who are most traumatized, that is often the real long-term consequence, as I say, that gives rise to a whole range of later emerging symptoms. But these are injuries that were there long before the person discovered substances or started to feel depressed and disconnected and anxious, and they were learned very, very early on. Really powerful scripts around not trusting people, not allowing connection, keeping yourself separate, relying on substances far more than on people. I think treatment is obviously useful and important, but I think, as I say, if we were to be trauma informed, I think we need to really, really think about how we have organized ourselves in a way that takes account of the sort of relational injuries that those with the greatest level of trauma, I think, have experienced. I'll stop there. Thank you for that.
Thanks, Adam. That was really helpful presentation. Sadly, your letter of 2006 is not something that doesn't happen anymore. We saw an example of that quite recently in a part of Scotland. But I think that the whole issue of trust and the person that you described about having can speak the language of trust as a second language almost was really powerful to me in terms of explaining that. But just to say that if you have any questions regarding Adam's presentation, if you can use the Q&A tab, and we'll come back to that after Katie's presentation. But thanks, Adam, and we'll come back to you. And now I'd like to ask our second speaker, Katie, to present. Thanks, Katie.
Thanks very much, Dave. Just 2 seconds till I set up my screen. Yeah, so I'm going to speak about some of the experiences from a range of our research and peer engagement work, so a lot of our peer research projects as well. So I'll be speaking about that today, and we'll certainly have an opportunity to discuss some of the themes coming up, both from Adam and I's presentation as well later on. So, experiences of trauma-informed care. So this will be based on a range of evaluation work and research work that we've been delivering over the last few years. So everything from local area service evaluation work, our medication-assisted treatment baseline study that was about 11 experience perspectives just prior to the MAT standards being implemented. Also a piece of work in Dundee around burnout amongst frontline drug and alcohol workers. And also going back to the sort of COVID pandemic, also we looked at some COVID impact qualitative work in conjunction with Glasgow University. So a few different experiences that we'll be sharing today, and then also some case studies as well from people who've been recently working in the front line, and also from people that use services as well. So what does the standard say? So all people receive trauma-informed care. And the standard is broken down into sort of 2 key elements. So MAT services having an explicit delivery plan in place for delivering trauma-informed care that takes into account a variety of factors. So engagement with people with lived and living experience of trauma in all aspects of service delivery, of course, where they feel that that's important and want that to be included. Evaluation and improvement planning, developing trauma-informed leadership, growing workforce knowledge and skills, and promoting workforce well-being. So looking at that in the widest sense, you know, everything from supervision policies to looking at ways to reduce burnout, compassion fatigue, things like that. And collecting data and information to evaluate services as well. And then the second part of the standard is about a steering group being established to oversee the development and implementation of trauma-informed care across MAT services. And we're certainly aware of a number of ADPs who are already developing these steering groups. So this is what the standard says. So we're going to move on just into the actual experiences of people. And I guess when we looked at the themes, we can see a lot of the things that Adam is talking about directly from what people are saying in services as well. So first of all, one of the big things is awareness of available services. So people not only not necessarily being aware what's actually is there, but also how they access it, what the criteria is, what's the pathway as well. And when we come to staff, we'll see that that's a theme that's carried across as well. Lengthy waiting lists. So again, that can be really different depending on what area you're in and what service we're talking about. But certainly when we come to some of the quotes from people, you'll see that people can be waiting months, over a year. You know, it can be a really long time. And then just the practicalities of accessing services. So people talked about, you know, the kind of standard opening hours of services, and then also travel. So certainly in some of the rural locations, people are talking sometimes about 2-3 buses just to even get to a service. And of course, not everyone necessarily has access to free travel as well. So that can be quite a cost prohibitive thing as well. Caring responsibilities within the widest sense, so whether that's childcare or caring for family members. And then within stigma, people talk, you know, about a very broad range, so quite direct things, you know, so things like having to wait outside for their prescription, you know, if they're accessing the pharmacy and it being, you know, very obvious what they're there for, and just feeling that affects their confidentiality. But then also if we think about maybe some of the work with women, women talked about maybe quite a gendered nature to stigma sometimes as well. So, you know, women being seen as mothers and carers and things like that, and maybe just having a different flavour to the stigma for them. The impact of COVID-19 came up as well. So, you know, whilst sort of post-lockdown, people talked about some of the services actually just not really returning to how they were. And obviously we've seen great things about practice within COVID-19, but then also challenges just about access, and then just a lot more like phone support and things like that. And whilst that works for a lot of people, for some people that was just really challenging as well. Time limited supports, that comes up time and again. People talked about quite a range of experiences, so whether that was like short-term counselling that maybe wasn't quite long enough for them, but then also like maybe people on orders, for example, so maybe getting a lot of support when they're on a criminal justice order, and then actually feeling that that changed quite a lot. And similarly with women talking about the support when pregnant was really different to sort of postnatal care as well. A lot of people share about criteria, so things like the need for stability within use, and then when people were sort of describing what that meant, what they were really saying is they were asked to be abstinent, and often for, you know, a time period as well before they could access certain services as well. And then other clients sharing about thresholds, suggesting that they're too complex for the service, but maybe not quite meeting the criteria for a more specialist service. So just really getting lost in those gaps there as well. And then, you know, a little bit like what Adam was describing, you know, just the gatekeeping that can come with some of the systems. So people actually just never making it to an assessment, you know, a proper assessment about trauma and their sort of mental health symptoms resulting from their trauma as well. And just finding that really, really difficult. So not necessarily having a diagnosis or anything like that, and feeling that that might be useful to actually be seen by someone that can provide an assessment. Poor first contact experience, so a bit like that letter, you know, and we have seen examples of this, you know, fairly recently as well. Just the actual, what's written in the letter just isn't necessarily trauma informed, and, you know, suggesting that people will be discharged if they don't turn up and things like that, and immediately sort of suggesting that there might be difficulties accessing the service. So if that first contact experience isn't good, people are less likely to engage with the process. And just lack of contact from services as well. So people talking about a real struggle to get hold of workers, workers changing, them not being updated about that kind of thing as well, and that just being a big challenge. And then finally, historic negative experiences. So what we've certainly seen with a lot of our service evaluation work, you know, we can see services that have transformed their service provision and actually are really different from the service that they operated, you know, 5 years ago. But actually people's experience was a few years ago, and they're still holding that when they go into those sort of first appointments. And that's where the first new contact episode is really important, because we might be having clients that are attending with you know, various challenges and baggage from the past as well. So I'm going to cut now just to hearing some experiences directly from people. So these are direct quotations from research, and we've just asked a range of, I'll say, actors to read them out for you as well, just to protect confidentiality. So I'll cut to them now.
Prior to COVID, I was receiving support from a psychologist. However, since lockdown, I've been signed off from this support. The services refused to work with me unless I stop drinking alcohol, which I cannot do without support. I'm not able to stop drinking unless I get help, as I'm suffering from severe anxiety and depression and use alcohol as a crutch.
I understand that there's a big waiting list, but I think if they were just to sort of keep communicating with you to say, look, we haven't forgotten about you, we're trying to get you help and support, but just a wee phone call to say, look, you know, is there anything that we can do for you? We've not forgotten about you, your referral is still in.
If they can actually get back to people, as they don't actually get back to people and let them know what is going on, what's happened, or even say to them, oh, your worker's off sick, or you've got this worker is supposed to be your worker until your worker comes back on. She never even contacts you. She never gets back, even if I phone.
I couldn't phone them as I had 3 workers in the past year and didn't have that kind of relationship with them to phone and say, I'm struggling a bit today.
There's a lot of waiting for people to get in contact with you. Yesterday I waited 10 days for my worker to get in contact with me. She's working from home, but I was phoning because I was having trouble and she didn't get back until 10 days later.
You're using it for a reason, aren't you? Is to suppress something or block something out or just to get through it, you know. I think there's always some sort of trauma there or something underlying, isn't there? And then using that substance just then exacerbates the mental health.
Very anxious all the time, and I get myself really low at times where I won't come out of my flat. I'll sit up all night because I can't sleep, and I just get, you know, and I have panic attacks sometimes when I'm coming.
It should be more 24/7 than 9 to 5, as people can have bad mental health at 2 a.m. as well as 4 p.m.
Anyone who has mental health problems, in my opinion, is abandoned to be seen. You have to be suicidal or turning up at A&E, you know, and that shouldn't be the case. There should be services that your physical health and mental health are dealt with separately. I'm not just talking about going to a psychiatrist who you have been referred to. I'm talking about a regular check-in with someone, how you're doing, how you're getting on, because I think that is important, especially with people with trauma addiction and mental health. I don't think there is enough support.
When you've bad mental health, you can't wait 18 months to see someone. If you broke your leg, you wouldn't have to wait 18 months.
On the system there, you're green, amber and red. Apparently I was down as green, so they didn't have any concern. I was like, well, how can you tell how I am over a fucking phone?
I'm just going to show just an audio case study as well, just about someone's experience of accessing services.
I've been going to see various GPs regarding my addiction and mental health for a number of years. I've seen one psychiatric nurse who assessed me when I was about 22 with no diagnosis. I've since overdosed at the age of 25 on a number of substances, and I've been battling recovery ever since. However, recently I tried to self-refer to a public service for support with my addiction and mental health. It took a number of weeks to get a phone call assessment where I was told my traumas were too complex for them to deal with, as they class themselves as a short-term service. I don't go to my GP for mental health anymore, as they seem to think that if I stay away from substances, I'll be fine.
So quite powerful experiences, as you can hear. And now we're going to hear a little bit about staff experiences as well. So yeah, challenges for staff, again, if we look at it in themes, included, similar to service users, limited awareness and lack of available services for onward referral. So, you know, just not having the range of options, but then also not knowing what's there and again, how you access. And the waiting list support came up as well. So, you know, supporting a client when you have referred them and they're maybe waiting for that more specialist support, but it's going to be a really long time, and just staff feeling sometimes quite ill-equipped to deal with the support, the complexity that people might be presenting as well. And again, for time limited supports, what happens on the other side, you know, if the person is still engaging with their service throughout, you know, what will they be sort of picking up on the other side? And again, do they have the sort of knowledge and skills to do that? Probably unsurprising to our audience, staff shortages and capacity issues. You know, we know it's a key issue in the sector, so that ranged from everything from like absence, covering for other people, staff retention generally, pressures of supporting new or less experienced staff, so you know, having to induct a lot of new staff and you know, having to do that on top of a very full caseload as well. So all of these factors. And then, you know, again, sort of post lockdown, you know, staff saying like, look, workload has really increased, you know, we're getting more referrals, there's greater demands on us, you know, we're getting higher risk clients, there's just like a lack of other service provision, and often some services feeling like they have to fill in those gaps where the other services are just not sort of accessible or appropriate for people. And then again, you know, burnout, empathetic distress fatigue, which is maybe an alternative term to compassion fatigue, and also vicarious trauma from doing this work as well. You know, these were all things that staff highlighted. And again, we're going to just cut to some of the quotes that are on the screen.
Where do you go? We have at times been there and you're phoning around all these mental health. Nobody is there to help, their GP, their CPN, and literally this person's suicidal. They're telling me they've got a plan and I'm stuck with them and I don't know where to go.
The ability in accessing drug and mental health services for my service users has been proved difficult. By advocating on behalf of my service users, I have personally experienced feelings of being ignored by services. If I, as a worker, feel this way, I can only imagine how service users feel.
They've to phone at 8 o'clock in the morning, so most of them are no up. They're on hold for 40 minutes, so there goes most of their credit for the month on their phone. And then they get told there's no appointments left and they have to start it all again the next day. And sometimes it's 4 or 5 days just to get an appointment.
We are sent endless COVID update emails about looking after our mental health with no time to read over these or action them.
My anxiety levels start to build before work. I feel confused about the task in hand due to multiple demands and increased capacity. I feel physically exhausted, but I'm only doing mental type of work. I feel on the defensive. I'm stressed at being able to cope with caseload demands and service demands if service users are unallocated and staff off sick. I avoid doing things as it creates more work.
If you've experienced trauma yourself, you know, and I think a lot of people within our industry have experienced life and perhaps experienced trauma of some sort, and that's kind of what drives a lot of us in this world of work, you know, because we feel we can empathise, we can relate to others, and we want to use some of that passion and that care in helping others. It also perhaps makes us more susceptible to burnout as well.
You're constantly firefighting kind of thing. You put one fire out and think, yes, we're getting somewhere, but then there's another fire and another fire.
We place an emphasis on trauma-informed practice. I mean, what about the workers? What about their trauma that they're experiencing? Where's the support? Are we inhuman? Are we supposed to just get on with it?
The psychologists come in and do reflective practice sessions with the staff once a month. Because we've got that link, we can just phone them, discuss a client, discuss a possible referral. They're really, really supportive.
Okay, and again, I'm just going to play a couple of different audio case studies as well from staff that have been working in frontline services.
Duplication of stories and a client telling their history is something that I think is definitely a barrier that's created within different services for different reasons. My personal experience is working with clients. We would do an initial triage assessment and then do a follow-up full comprehensive assessment. But if a client was typically going for MAT treatment, so any of the 3 main opiate substitute treatments, often they would then be re-asked these same questions via NHS within the area, despite the fact that we would have sent paperwork already covering this, potentially because our assessment isn't deemed as clinical or thorough enough. I think small things like this create real difficulties with clients in engaging, and people don't want to be telling their stories over and over again. And I think if there was a way that paperwork could be co-joined up between different service providers, third sector, voluntary and NHS, that's a way that we could look to support better trauma-informed care.
One of the changes I've seen in agencies and organisations that can make a huge difference in a shift to services being much more trauma-informed is around communication and being able to make informed choices. We can talk people through step by step what is happening, what they can expect from the service, how long things take, what happens next, but also throughout making sure that the person understands what you're telling them. Everyone can get anxious when interacting with new situations. If you have other challenges also going on in your life, it is often even tougher to make sense of it all and retain this information. Our role, I feel, in providing services is to make that process as straightforward as possible, working with the individual, discussing things like, are some days easier to come to appointments than others, or are there certain times of day that are better? Also talking through things like, would it be helpful to write down the information that we're discussing or recording it on a soundbite on their phone? If they swap phones around a lot, is there a trusted person that they would provide permission to be contacted so that that person can remind the individual of appointments? To be trauma-informed, we need to discuss options, be person-centred, let them know that they have choices, and it's okay to ask to have their needs accommodated. If there are reasons things have to happen a certain way or at certain times, explain why and try to work in ways that will navigate challenges which can become huge barriers to engagement.
Okay, and again, some thoughts there about, small changes to practice. So I'm just going to really leave you with a quote, really, from the Dalai Lama. So love and compassion are necessities, not luxuries. Without them, humanity cannot survive. And certainly what I would say from my research work and my own clinical experience working as a psychotherapist, as well as, never to underestimate the small things that we can do to individual practice. And I think it's clear from the findings that, there's definitely system level change that needs to happen, but those small things that we do have really deep roots for people and sometimes are the absolute difference in helping someone engage in a system that isn't always trauma informed, but certainly our individual practice, it really, really matters. So thanks very much for listening. I'm just going to stop sharing and pass over to Dave.
Thanks, Katie. That last point's a really important one. Could I ask Adam to come back on screen as well, and also my colleague Austin, who's been monitoring the questions. So we've got till 2:20, so we've got quite a bit of time for discussion and questions. Austin, do you want to kick off? I know, goodness me, there's a lot of questions coming in now.
Yes. I'll try and do them justice. This is a problem that we can come up with answers at the very end, questions at the very end. I suppose the first one is just about how ready the field is for the implementation of the standards. Is being trauma informed still a sort of almost a peculiar or a specialist interest, or is there more of a consensus not only that something needs to be done, but we know what to do?
Who wants to take that first, Adam?
How long have we got? Oh, we've got a while, haven't we? But I'll keep it brief. I think there's some precursors to it which we haven't fully grappled with, and I think it's really, I thought Katie's presentation is really powerful in terms of, if you take some of the themes that are coming out of it, often they are about relationships. I think they're about availability, continuity. Is the person there? Am I being thought about? Am I in someone's mind? There's a concern about the connection. And I said it right at the beginning. I think all healthcare is relational. And if you're really good at relationships, you don't notice it. You go along and you do the healthcare and you don't notice that the relationship is in some way important in terms of you going to see your GP, for example. And I don't know that we've fully grappled with that. And I think until that has been really in with the bricks in terms of how services are actually designed and thought about, then I think it'd be very difficult to implement some of these standards. Not because they're bad or there's any problem with them, but I think, as the question is asking, the context and the environment into which they are landing may not be sort of prepared for them. I think MAT 10, in essence, it's written into it. It's saying, once you get here, here's all the stuff that we'd like to do and make sure that is in fact, a lot of the standards are saying that once you get here, once you're in treatment, here's all the stuff that we can do. And slightly sort of misses that for a lot of the people who might be in this sort of treatment or might benefit from this sort of treatment, one of the real consequences of the experiences that have led them to have relationships with substances are about their, as I say, relational injury and their capacity to form and maintain relations. So until that's really understood as a sort of fundamental in health and social care provision, then I think anything that lands into it is going to struggle to sort of take full effect, really, because something of that real base level precursors aren't really established, I don't think.
Katie? Yeah, maybe just to add, I would say that, it probably depends what type of service you're in. I guess people that are working in more of the psychological services as well, there's a much greater understanding of, you need to work really long term with people, you need to help with engagement, and I would say that in a way the third sector is set up to mobilise to all the different ways of engaging with people. It just feels to me that in some of our services, both statutory and third sector, the service design is quite rigid, and that it's very target driven, and it really doesn't take account of the longevity of the work when you're talking about complex trauma as well. So, if I think about my own clinical experience, I work in a trauma and homelessness project. You do have to do much greater techniques to engage, it's not just one appointment reminder, it's often phoning people multiple times in a week to remember. It's people lose phones, people have to sell their phone to survive. It's just thinking about all the things that can really happen to people. So that first contact experience, if we just sort of imagine that, well, someone isn't wanting to engage because they haven't turned up to one appointment, that to me is just inherently not trauma informed, but in a way that process is driven by the system. It does feel to me that staff and services do have a universal understanding of what trauma informed care is. When we start thinking about drug and alcohol services, and certain universal services that wrap around that. But if we start thinking wider and think about GPs and things like that, I'm really not sure that understanding is shared across as well.
Thanks, Katie.
I think that's true. I would completely agree with that. But you're right about the structural stuff. So if you take, for example, things like the local delivery plan sort of outcomes, which say, we want 90% of people to be seen in 18 weeks, that becomes a tail that really starts to wag the dog, because at the other end, we have services who are trying to discharge people, or consciously or unconsciously aren't necessarily wanting people to get there, because they're always trying to run to a particular target, which isn't necessarily in itself trauma informed or in any way evidence-based, but is a set of numbers to try and, more a political ideal rather than a psychologically or trauma-informed sort of position. And I think you're right. There's definitely people who would want to work in particular ways, but they might find themselves in systems that are not set up in ways that have been informed by sort of, relational understanding.
Yeah, and certainly, a lot of the work that we've done has shown issues of retention as well, of course, as part of that whole thing. So it's not just about the first engagement. Obviously, it's about that continuing, and the risk of people dropping out is significant for many people. Certainly with the over 35s work, where a significant proportion had 10 or more episodes of being in treatment, which says a lot about the system as it is. Austin.
So Adam's spoken about the difficulty people have accessing services. Now we might make fewer barriers to people accessing services, or make access easier for people or possible for people. But once people are in a service or have arrived, there's the conditionalities. So there's professional limits, or what regarded as professional limits, about people being stable enough to engage, and then there's a conditionality around, you know, interventions that are time limited and so on. So I just wonder, how do we have an understanding of why those barriers exist? Is it simply because we're not trauma informed, or is there other issues?
I mean, for me, I'm just thinking, you know, just sometimes the time that's needed to be truly trauma informed, you know. So again, you know, I'm thinking about my own clinical work where, you know, if you're working with people that are, you know, rough sleeping, you know, you do lose them, you know, and it's really easy to discharge people, you know, at that point because you can't contact them. So in a way, it is about the time that's needed in services to be able to really offer that level of engagement. And it feels like that's really related to staff burnout to me as well, that, you know, staff are just asked to do a lot with a very short amount of time, and actually the system itself starts to burn people out. So we talk about burnout and, you know, empathetic distress, fatigue, you know, that's as a result of doing the client work. But actually what a lot of staff say is it's not the clients that's the problem. You know, that's the part of my job that I love, but I feel a bit cynical about the process as well. So I think that's a key factor.
Adam?
Yeah, I really want to echo what Katie's saying around time. I mean, time is, again, it's going back to that invisibility and trying to really articulate what we mean when we sort of talk about trauma from a sort of relational sort of point of view. And I've used that term relational injury. I don't know what that means. I mean, I only used it to try and sort of compare it to what we understandably do for physical injury, in that we wouldn't, you know, we don't, not so bothered about, you know, spending hundreds of thousands of pounds on someone through an operating theatre, post-operative care, ambulances, emergency services, wheelchair, all sorts of stuff that is necessarily important if somebody has suffered a physical trauma and a physical injury. And yet we really sort of, I don't know, in terms of psychological injury, relational injury, it's sort of, well, we, you know, it's 12 sessions and then really, you know, that's the limit. Now that's not informed by need. That's not informed by an understanding of how humans work and of what the sort of consequences of trauma actually are. It tends to be much more informed by a political ideal or the resource that we have available. And I think my argument is we can really sort of articulate what we mean by something like relational injury, then we can start arguing for what an appropriate resource would be if we truly wanted to be trauma informed and have the time and the space to give ourselves a chance to repair some of the sort of long-term life-limiting consequences of relational trauma.
Are we moving closer to that understanding, Adam? Because I mean, I remember, you know, when a lot of the debate and focus was on, you know, people with a substance problem, it being a lifestyle choice rather than, you know, underlying issues for people. Do you think we've moved forward on that understanding? I know you're saying we've got a long way to go still, but
I'm with Katie. I would hope so. Certainly thinking in the area that I've worked in and around homelessness for 20 odd years, and definitely the rhetoric and the understanding within workers' minds and within services of, you know, we tend to be working with people where homelessness is a late emerging symptom and it is related to early experiences, adversity, trauma. I think that's all much more understood than it certainly was when I was around. But I guess we have a whole lot of historical structures that don't have minds. There's people in those structures that have minds, but the structures themselves are still the structures. We built this building, so we're going to have to keep doing the service in this building, even though the people in the building might have a different understandings about what is needed. I feel optimistic in terms of the rhetoric and the more general awareness and understanding. I suppose the bit I'm, you know, then get sort of frustrated about is how that then relates to structural operation, really, in terms of, like you say, we're still sending out letters, we're still expecting people to come and meet us where we are. We still have, you know, arbitrary figures like the local delivery plan that says we want this amount of people in this amount of time. We still have things that say this is a psychological intervention and this isn't, and this is a tier 4 intervention and this is a tier 1. And like in some way, the unconscious of the people that we work with can make that sort of distinction about what is useful or what is not useful. You know, they're much more about, you know, our needs as professionals or as systems rather than you know, the needs of the people we're trying to serve. So I do think there's progress. I really do, in terms, certainly, as I say, in terms of the rhetoric and the understanding and the language around things, and the fact that we have a NEST trauma training framework, and that we have MAT standards. This is great. This is definitely improvement. It's trying to really sort of shine a light on what that means in terms of how we actually organize services. And if we were, you know, building things now from scratch, from a blank page, with these sort of understandings, what would it look like? I don't know that it would look like geographically disparate clinics based in places where people come along and sit in rooms for 50 minutes. I just don't think it would look like that.
And is it also the problem of, you know, the labels to get into particular services that you know, whether that's mental health, substance use, or criminal justice, or homelessness, is that part of the challenge of delivering this? It's a bit of a rhetorical question. So I was expecting some sort of answer, at least. Anyway, you could just nod your head saying yes. That's fine.
I guess I was just going to say about those sort of gaps, Dave. You know, like you know, we've spoken a lot, you know, SDF conferences and many conferences about the gaps that exist, and how a lot of the original reports, you know, going back even 20 years, you know, the findings are all the same. We haven't implemented them. So in a way, we have really robust frameworks, you know, things like the trauma training framework and things like that. But it is the implementation on the ground that's difficult, and certainly the criteria that happens between substance use and mental health services, that's really tricky to navigate. It's tricky for me referring into it. So, you know, I think one of the quotes talks about that traffic light system. I've encountered that as a referrer, you know, and how someone's sort of coded, and it, you know, that to me just feels like a completely bizarre way to navigate into the service. And if I'm struggling to refer someone in who quite clearly has complex trauma, but they're not quite meeting the criteria for any of the services, you know, how on earth are we expecting people who are living with complex trauma to navigate those? So yeah, it feels really impossible for people sometimes when they are just falling between those gaps.
Yeah, I mean, it's that, I agree. I think it's that sort of fragmentation of, I might argue that a range of late emerging presentations, whether that is homelessness, relationships with substances, mental health problems, they are late emerging symptoms of earlier difficulties that we don't tend to have a specific service for. So you're going to a service for these specific things. As I say, we don't have a trust repair service or a relational injury repair service. I think there is services that look like that. I'm always a sort of slight joke to say, you know, I'm sitting in one just now. It's called a sort of family home, and my children have been in treatment for like 16 and 14 years, and they're not quite ready for discharge yet, but it's all integrated in one place. And hopefully, if the treatment continues going as is, they might be discharged at some point, and off they go, and they can come back and seek care and support and all the sort of stuff that's been in this place as they go on through life. But when we come to actually look at the way services are organized for people who haven't had that sort of security in their upbringing, it looks nothing like a healthy family home. It looks like, in fact, it ends up looking a lot more like the sort of fragmented and problematic history that they've come from than it does like a healthy home or a healthy sort of relational environment.
Okay, we may come back to that issue in terms of just the way services are organised before we finish. But Austin, I'm just conscious that there's probably a lot of other questions that have come in.
Yeah, well, there's a couple of questions about, you know, practical steps for implementation. So I suppose one of the problems with this standard is it's everybody's responsibility, but therefore no one's. And where do you start? It's asking for an overwhelming cultural change. So, and that's, I know it's all interdependent, but where's the priority? If you imagine you were an NHS accountant, where would you invest in the training for frontline staff and the changing of systems and management within systems, or in you know, changing the physical environments in which we're meeting people?
Who wants to take that first?
Well, for me, it's you know, there's two very clear levels. So there's systems level, you know, and it is about, you know, obviously services need to be adequately funded for the work that they're doing, and they need to be able to offer long-term supports to people, which a lot of the time they just aren't able to do within the current criteria. But, you know, absolutely, staff training is really, really important, because what we find when we deliver training is actually for a lot of the staff that are really worried maybe about doing that sort of waiting list support, you know, holding people while they're waiting for a referral, is actually they are really competent and able to do the work, but they feel a bit out of their depth. So it is maybe about the support to enable them to do that. And there's some fantastic work with psychology services about actually them working alongside substance use services, like sometimes bringing a psychologist in one day a week, or you know, whatever that is. Those things are really, really clearly helpful for people. But you know, at an individual level, I would just kind of go back to that sort of point I was making in the presentation. We kind of forget about those small things and don't realise how much impact. So certainly in some of like the women's work, for example, women were saying things like, do you know, my worker just phoning me back, remembering the name of my children, you know, just those small relational things that might seem really trivial to us actually are absolutely massive at helping heal some of those relational wounds that Adam's talking about. You know, if we think about it through an attachment lens, you know, attachment injuries are healed through positive, good attachment. So we cannot think it's just about the systems. It's both our individual practice, but it's also at systems level.
Yeah, thanks, Katie.
I would echo all of that. I think there is other bits around. I still think there is some arguments to be won around the kind of theoretical underpinning of what we're talking about here. As I say, we don't really have a concept of somebody's major life-limiting condition being the relationship they have with care itself. We don't have that. That's not a thing. And we don't really have a service, if you like, that would address that. We don't have a trust repair service. We don't have a relational injury repair service. It's not a thing. It's not something that's seen necessarily as massively important. And I think, as Katie's saying, to the point where we talk about that callback as these are little things, as opposed to, no, they are the treatment. And what we value is treatment. And I know I come from a profession that values the treatment. We structure it. We say, this is tier 4, this is tier 1, and this is like we place a hierarchy on what we think is important. And yet in the area I work in, which I think, you know, contains some of the most traumatized people, when we've asked people what's helped, they've never said sitting in a room for 50 minutes doing a 3-letter acronym therapy. They've just never said that. They've said things like, you know, I thought somebody really gave a shit about me. And the reason I knew that is because they did call me and they remembered my name and they checked in with me and they remembered that I was doing something that day that would be worrying. And that's the sort of thing that really, really has an impact in terms of building connections and trust that might then allow somebody to make use of other things that are undoubtedly helpful as well. I'm not throwing the baby out with the bathwater. It's not that I don't think psychotherapies of any tier aren't useful. I think they are. But there's a lot of relational bedrock that's required before somebody can come along and make use of that sort of stuff. And I think those are incredibly important treatments too. I wouldn't want that sort of hierarchy of which one is more important than another, really. I also think that there is, like you say, small bits of practice we could do just in terms of thinking about things like missed appointments and how we manage those. And obviously there's a pressure to discharge people if they don't engage because we've got a whole lot of other people on the waiting list. But we might turn the language a bit to, you know, rather than you DNA'd, we might be thinking, what did we not attend to such that you didn't get here? Not that you didn't attend, we've not attended to something because clearly we know about you in distress and you had a referral here and then you didn't come. So we've missed something. Clearly we've missed something, or we're not getting something right. And how we sort of think about those things rather than keeping locating the problem in some of the most vulnerable people in society, like it's their fault. I think it takes a specially trained mind to keep locating the problem in those with the least power, rather than actually thinking about how is it that we're positioning ourselves such that what are we not attending to, such that we're not seeing people who are undoubtedly in the greatest need.
Yep. I suppose just coming back to the systems level issues and obviously, you know, the things that staff can do themselves, but the system level, is the problem fundamentally about how we organize the services? And I suppose part of that is around the commissioning. Obviously the commissioning is only the third sector, but is there something around that we should be looking at to deliver, you know, as you say, those sort of trust services at the front end. I mean, I'm also mindful, you know, we've talked about, or there's been a lot of talk around drug consumption rooms, for example, and some of that, to me, is about delivering services where people are. So you start where people are, so you have the low threshold, easy access, so you can start to build that trust. Is the problem that we don't have, you know, those bottom tiers? We've almost, you know, built up the barriers, like you say, Adam, you know, similarly to the staircase for people with actually underlying trauma. I don't know quite where I'm going with that, but Adam, do you want to respond to that?
No, I think that's kind of what I'm like you. I get lost in trying to describe it, and I don't want to oversimplify it, but it's almost like for people who can do relational breathing easily, it's not a problem. You know, people can come and access this, that, and the next thing. It's recognizing that part of the treatment, we have this goodie at the end. Let's say, well, let's call it medication-assisted treatment. This thing. And we think that's the treatment. But for some people, there may be a massive precursor to that the medication-assisted treatment doesn't take a long time. The building of the trust may take 10 years. I mean, I was talking about it in another area in relation to cervical smears, which is, you know, might take an afternoon. But for some people, there might be 5-10 years of building enough relational security to the point where the person felt safe enough to go and have a procedure like that, which doesn't take long. And yet we think that's the procedure, that's the treatment, as opposed to, no, it was the 10 years of building connection. That was the treatment. The happy side effect at the end was that the person could go and get a cervical smear. And I think it's a bit like that for this, that here's the treatment we have. We think this is the treatment, but there's a precursor to it for some people, which is the building of relational security, trust, connection that might allow the person to access treatment. And that does involve going and meeting people where they are, actually, you know, rather than waiting for them to come to us, in my experience.
Thanks. Katie?
Yeah, no, just absolutely to say that, you know, inreach into, you know, these types of services. So, you know, we see that with like a lot of our like homeless access points and things like that. So if we looked at a drug consumption room as an absolute opportunity to meet people where they are, you know, so services that could inreach into that maybe provided some of the trauma-informed care, that to me would be an absolute no-brainer.
Okay, thanks. Austin?
Yeah, well, I suppose with the MAT standards, we'll have to measure progress towards the implementation of that standard. So how do you do that, or how would you do it? How do you know you're making progress if you're managing a service and you're trying to implement this stuff? What does it look like, and how do you measure the progress towards implementation?
Katie, I think that's one for you first.
That's a big question. I guess what I was going to say as well, that, you know, obviously that, you know, there are some great resources that we've got. We've mentioned the Trauma Informed Care and Practice Organisational Toolkit, and it's got a lot of suggestions around baseline assessments and things like that. But, you know, it is thinking about physical environment and things like that. But, you know, in its broadest sense, so as Adam mentioned, you know, that we might have chosen the building. So sometimes there can be this like, oh, we'll have a living room atmosphere in the waiting room, and that will fix the access issues. But, you know, we need to think about the physical environments much broader than that. And it, you know, goes to the building choice itself as well. You know, thinking about how we meaningfully include lived and living experience within that. So not tokenistic co-production, but really bringing people into that implementation. So, you know, these would be quick things to assess against, you know, what is our environment like? What are the barriers? You know, what kind of lived and living experience involvement do we have? You know, what is in the toolkit around baseline assessment? So these would be maybe quick wins, but, you know, of course, it's about the sort of burnout aspects. So trauma-informed care happens from within. So if the staff are all burnt out, it's unlikely that they're going to be providing that trauma-informed care. So there's many measurements for that, and we certainly hope to be doing a bit more work within SDF around that area as well. But I'm sure Adam has other thoughts.
A few, like you, Kate, I think it's just a sort of massive question in some way. I think, funnily enough, the one that sort of comes to mind to try and mention is an interesting outcome would be where the resource allocation is and how much it changes over time. Because I think it's all right to have the standards, but if you have a sort of flat resource allocation, it's going to be hard to implement some of these. So almost a good, very concrete outcome measure of how trauma-informed we were being would be, you know, is there an equivalence of resource being allocated to relational injury in this areas and other areas as there is to physical injury? You know, are we getting a comparatively same amount of money that goes into critical care in hospitals? You know, that would be an interesting measure, you know, rather than just having documents that say, oh, we should be this and we should be that. Okay, that has resource implication. Exactly as you've articulated, if we want our staff to be getting, you know, to be relating to people, thinking about people having time, it might mean caseloads of 5, 6, you know, like happens in intensive care, you know, where you're not expecting the nursing staff to be looking after 45 patients because they are in trouble. Well, actually, a lot of the people we work with are in that level of severity, but just not physically speaking. So what is actually the resource implication? So I think, as I say, a good measure might be, you know, are we getting more resource that recognizes what it is that we're actually doing here?
Thanks. Austin.
Oh, I think that's my question, Dave. I don't know if you've got a final question.
Well, I suppose it was to you know, to go back to the, you know, the question, if we were starting from a blank sheet, you know, how would we do things differently? I suppose we've touched on all of that, but I suppose the question I had was in terms of the, you know, I suppose as I alluded to, in terms of, you know, different populations that we talk about in terms of people with substance problem, people with mental health problems, offenders, homeless people. Should we not be commissioning services that recognise the underlying trauma of most of those individuals and organise services differently to the way we are? So I know that's we're skirting around very difficult questions for this, but Katie, do you want to have a go at that first?
Yeah, I mean, I guess I would argue that we probably are commissioning services to do that, but we're not necessarily resourcing them adequately. But I think one urgent thing that I think we need to address is this notion of stability. You know, for me, that is a constant thing that's often quite individual, people's interpretation. And, you know, it just isn't realistic to expect people to be drug and alcohol free and often for a period of time, you know, and also people actually can be on quite what might be described as high levels of substances and actually be able to engage in, you know, trauma work absolutely adequately. So it's got to be really individual as well. But I think we need a lot more guidance about that, because that comes up time and again in staff training.
Do you want to be a bit more specific around that, Katie? Is that, yeah?
Yeah. I mean, so for me, certainly in my clinical work, we don't have a threshold for, you know, someone, we can't work with someone that's on this much OST or is using this many street benzos or whatever that is. You know, it will be entirely individual, and you'd be working with someone for a few sessions to be able to see what level that they could engage with a psychological process. And I feel like that's what needs to happen, but it's almost like immediately that's used as a gatekeeping aspect, so people don't even make it to the assessment because they're already too chaotic, so they've never been seen by anyone who's actually qualified to assess them, and that's maybe decided by a staff member without that expertise. So that to me is a real problem that we need to address.
Adam?
Yeah, I mean, at the risk of sounding like a stuck record, I think you know, recognition of that across the areas you describe, whether that's criminal justice, homelessness, mental health, relationships with substances, relational continuity might be a really, really important factor in all of those areas if you want people to be able to access some of the goodies that you have at the top of the stairs, really. And that recognizing that relational continuity isn't a sort of nice add-on or a precursor to treatment, but is the treatment. It might have the sort of consequence that the person can access other stuff, of, you know, whether that's physical healthcare, mental healthcare, whatever, it might specific sorts of interventions. But in and of itself, it is the treatment and an important part of treatment. For some people, it is the life-saving treatment. Now, I do think we do some of that. I think there are organizations that do that. And the people are called things like support workers and project workers. And actually the work they do is incredibly poorly valued, both financially and I think from a sort of recognition of the importance of it sort of point of view. I don't think it's like often the characters in the support worker does this stuff and gets the person to where the goodies are, rather than, no, they've done the treatment, which now means you can deliver something that might be of use to the person. But this was just as an important part of the treatment. So I think it would be, you know, it is individual and it would be individual across different services. But we know even in relatively healthy populations that having the same GP, for example, has big health benefits for people, even when they haven't got huge relational injuries. So in areas where we know people have got very severe relational injuries, having relational continuity might be really, really important. So if you want to try and do, for example, some psychotherapy with somebody, there might be a 5-year lead into that, where you're just meeting them where they are and having a coffee and doing all sorts of other stuff that's just about connection, really. And in and of itself is psychotherapeutic, which might then lead at some point where we're talking about something more focused or more specific. But it's not like the focused specific stuff is more of a treatment than the lead-in. Like, what I'm really arguing for is that the whole thing is embedded within the sort of relational continuity and connection. And that is really the core element of treatment in terms of addressing the relational injury consequences of severe early childhood trauma.
Yeah. And I think certainly all of our studies over, you know, 20 years or more of the peer research have you know, shown that, where people mentioned an individual that has gone the extra mile with them. So you know, that seems to be the, well, not seems to be, I think it is the key as you describe it. But how we get there, I think, is yeah, we're going to have to come back to again, I think. But we're going to have to end it there. But thanks so much for your contributions, and hopefully the audience found that interesting and point us to improve practice in this area. So
thank you, David. Thanks everyone for your time.
Yeah, thanks Adam, Katie, thanks. So we've come to the end of the webinar. As highlighted, this was the last in the series of webinars on MAT standards implementation, and I hope you've found them useful. And if you haven't watched the other standards, as I said, they're all up on the YouTube channel, or will be shortly. So finally, I'd just like to thank you all for attending, and a special thanks to today's presenters. So that's really all from us for these standards, and obviously we've covered a lot of ground in terms of some of the issues around progress with implementation, challenges that remain, and potential solutions to those challenges. But thank you all for attending today, and goodbye now. Thanks.